This is indeed pleasure to invite you for this 56th Peculiar Case Series in Renal Transplant meeting. And this meeting is somewhat special that, due to the extreme work, hard work put by Dr. Vellaran, our co-founder of this Peculiar Case Series, we are soon about to launch a new app because we have a lot of requests from the many nephrologists regarding inclusion of them in their group, in our group actually. So which we could not do that because of the restrictions by WhatsApp that we have already crossed 1,000 members. So we are compelled to innovate an app actually. So after a lot of hurdles, it is making a shape, and it will be launched soon. And once it is launched, it will be officially intimated, and it is possible that we could include n number of people into the group, and that has a lot of options. That is called as an FX. We have named it actually, and it has a lot of applications. And we will be coming with your trial soon. And this is as before. We for this meeting we have two interesting presentations, and one is by Dr. Vijay Sinha. Actually, I recently met him in Japan in WCM, and we had an interaction with Dr. Tanabe at Shogun Hospital, and he used to say about the CDC positive grass match transplant, CDC positive grass transplant. And it was very interesting, and we thought of inviting him to have a talk on this so that we get a lot of things, because many donors were being rejected by the CDC positivity and flow positive grass matches and all. And his presentation would definitely put a light on it, and so that many recipients will be benefited and many donors won't be rejected, as we have a lot of difference, a lot of demand and supply difference in transplant. And will be interesting and to look into your talk. And Dr. Vijay Sinha is a Senior Director of Nephrology and Kidney Transplant at Max Super Specialty Hospital, Noida. He's one of the most innovative transplant practices having, and this involves a lot of interest in us. And he had he was awarded a shining star from Times of India 2020, and he has a record of the oldest donor transplanted to a patient. And welcome, Dr. Sinha. And we had a good time at Japan, and hope you to have to deliver a good lecture, and we should take a lot of take-home points from your presentation.
Thank you, sir.
Joining him in his for his second presentation is Dr. Mahendra. He is not new to this platform because he has presented once, and this is second presentation. He is a consultant nephrologist from RANM Maladi Vijay Kumar Hospital, Erode. He is a young firebrand nephrologist who could be able to venture into the complex surgical complicated transplants. And with his friend, actually, his batchmate, probably Dr. Murli, a vascular surgeon from Tanjore Medical College. He is one of the important lighthouse for many of the nephrologists, because he will come in the rescue of many complicated transplants. And he used to do a transplant, and is very approachable and very soft-spoken, and yet a very knowledgeable and high wisdom with vascular anastomosis. He used to help a lot of nephrologists in transplant programs. Many of the transplant programs in type 2 and 3 centers go with his help, and he will be helping him with his comments regarding that one important interesting surgical transplant case. We have two panelists. One is Dr. Vishwanath, and he is not new to this forum. He is academically sound, very soft-spoken, and with a lot of wisdom. And he is a HOD of Nephrology, Manipal Hospital, Bangalore. And he did his alma mater of that institute only. He did his DRMP from that institute, and a lot of publications. He trained a lot of post-graduations. He also has a novel transplant experience, and his center is known for the high volume center, more than 100 transplant per year. And we had a good meeting, we had a good chat, and we had discussed a lot during our WCN meeting. And his inputs will be very much valid in this forum and this meeting, because it's going to be a good discussion. We expect a lot of good discussion from this presentation. Dr. Vishwanath sir, welcome to this meeting.
Thank you, sir.
And joining him is Dr. Jayant Kumar Hota. He's a senior consultant nephrologist in the Apollo Hospital. He's a good academician, and he has presented in various conferences. And he had a lot of transplant experience, especially this kind of high-risk transplant like HLA sensitized transplant and CDC positive transplant. And I'm sure that he will throw his inputs from his own experience of this kind of sensitized transplants. And without wasting much of the time, I invite Dr. Vijay Sinha to start his own presentation. Thank you.
Good evening, everyone.
Okay.
I think my screen is visible to everyone.
Yeah.
Okay. Thank you. Today I'm here because of Dr. Radharajan, who during an informal talk we discussed about the transplant in cross-match positive recipients. So I'm going to throw some light on how we do it at our center, what the steps we are taking, and what are the outcomes and the results. I know one of the most difficult, challenging tasks in today's scenario is to do transplant in the cross-match positive recipients. So still, I will try to do some justice to my talk and will definitely get valuable feedbacks and light on the kind of transplantation that I'm doing and that is going to help me further in my practice. So before I go to my talk, I will just show this screen to you that this gentleman, Tom Cruise, is known for the stunts. And I have given the topic boarding the train to the Mission Impossible because most of the time we are not going to transplant in patients who are CDC cross-match positive. And so for me, it was like doing a Mission Impossible task. And I will be presenting on the real world experience, my experience, the team experience of my team, and I share many of my experiences with Dr. Jayant Hota at many of the meetings and informal talks. So he is also a witness to most of these presentations that I have done and most of the work that I have done. And I have collaborated with him many a times. We have cross-checked on each other how we to proceed ahead. So we all know that there is a growing need for the kidney allograft. Prevalence of CKD is around 8 to 11% worldwide, and there is a drastic increase in the number of end-stage kidney disease because of the diabetes, hypertension, the aging population, and the incidence of ESRD is around 180 to 200 per million population. Looking at the current scenario in India, we have around 80,000 patients who are added annually to the pool of end-stage kidney disease. And we all know that kidney transplant is the most effective treatment for end-stage renal disease. Only 2.4% undergo renal transplant, despite the fact that kidney transplant being the most effective treatment, only 2.4, that is a very small number. And most of the time, the reason for not inability to transplant is non-availability of a suitable donor. Nowadays, the transplant cost has gone down, number of transplant centers have increased. So geographical reach has gone to most of the transplant recipients. The financial ability has also increased. Government centers are now doing transplant, but still the donor issue is always the Achilles heel in the transplantation programs at many of the centers. And this is the scenario of cadaveric donations in our country. For every kidney that is harvested, we have hundreds of potential recipients, and it's very difficult to judge which one would be getting. And in northern part of our country, still the cadaveric transplants in the phase of small growth, small steps at a time that we are taking in cadaveric transplants. Though in southern part of our country and the western part of the country, the cadaveric transplants have increased by leaps and bounds. So we need to urgently expand the donor pool. And what we are resorting to? We are resorting to APO incompatible living donations, kidney transplant from swap or paired kidney donors, cadaveric transplantations, and last but not the least, we are resorting to transplant from the HLA incompatible living or the cadaver donor. Historically, the immunological barriers were considered as absolute contraindication, but over the time, it has been re-evaluated and there are therapies which have emerged, there are protocols which have emerged, and that has broken this immunological barrier boundary. And now most of the transplant centers are accepting HLA incompatible donors. Looking at the sensitized patients, patients with a calculated PR of more than 80% are classified as highly sensitized, whereas those with more than equal to 98% are considered as very highly sensitized, and they are the ones who are considered as untransplantable. Looking at the data, 38.6% of the patients on the kidney waiting list are sensitized to HLA antigens of potential donors, and 11% of the patients have got a calculated PRA above 80%. And this subset of patients are very likely to get any live or cadaveric donor unless they undergo some kind of desensitization. Even with the acceptable mismatch programs running at many of the centers, many of these patients will still be left out from the transplant program. What are the challenges that are there in the sensitized recipients? They have a living donor but cannot receive because the positive cross match. They have longer waiting times for deceased donor. They have higher acute and chronic rejection rates. They have lower patient and graft survival. If you look this from this UNOS data, look at the PRA value from 0 to 9%, the 5-year graft survival was 72%. If the PRA is between 10 to less than 80%, 5-year graft survival is around 65.6%. And if the PRA is more than 80%, the 5-year graft survival is just 61.8%. We know the reasons for HLA sensitization, previous transplant, multiple pregnancies, and the blood transfusions. These are the three most common. Even one of the work done at our center, which we published in 2022, around 1,066 patients were screened with CDC cross-match, flow cross-match, and Luminex PRA. These are the subset of donor-recipient pairs from kidney transplant, from liver transplant. And we found that those patients who are undergoing a retransplantation, they have got the highest amount of antibody strength for the donor-specific antibodies, followed by those with having been sensitized by pregnancy and transfusion. We know the goals of desensitization. We want to increase the chances of a successful kidney transplantation, as well as we want to prevent the antibody-mediated rejection in patients after the transplantation. So this is the usual ideal goal that we all want to achieve with the desensitization. This UNOS guideline, which was published way back around 20 years back, says that if the CTC cross-match is T cell negative and B cell positive, or flow is positive for B or T, with a DSA of less than 5,000, that means single DSA of less than 5,000, and flow MCS less than 300, no pre-transplant desensitization required, and we can straight away go and transplant with ATZ and IVIG. So that was the held belief of from the different publications, and most of the transplant centers were accepting with DSA less than 5,000, single DSA with less than 5,000. It also goes on to say that if the CTC cross-match is positive for both for either T or B cells, and flow is also positive for T or B cells, with a DSA, single DSA more than 5,000, we can still desensitize them with plasmapheresis, IVIG, rituximab, and once the DSA goes to less than 5,000, we can go offer them the transplantation with ATZ as an induction. But it was that the patient has got a CTC cross-match positive, which is either T or B positive, with more than 3 DSAs or more than one strong DSA of more than 5,000. Then such patients are warned against desensitization, because we understand that these patients are not going to have a good graft function. Currently, nomenclatures have changed. Now we are looking at the DSA relative intensity score. We all know how to calculate it depending on the MFI of the DSAs, 10 points, 5 points, and 2 points. And if the DSA score is more than 17, we understand that there is a 91% chance of developing ABMR with the conventional protocol. So this guideline suggests that if the DSA RIS is more than equal to 17, do not perform desensitization. There is a higher chance of graft loss. We know the principles of desensitization: to remove the pre-existing antibodies, to prevent the formation of new antibodies, and continuously monitor of antibody levels and effects on the graft, and act wisely depending on the availability of the resources. Looking at the history of HLA incompatible desensitization protocols, there are 3 protocols which are mainly in play. John Hopkins protocol, which says plasmapheresis and low-dose IVIG as an antibody technique, removal technique, antibody synthesis blocking by rituximab, and induction with ATZ with maintenance immunosuppression standard protocol of CNI, MMF, and steroids. Then there came the Mayo Clinic. The difference was they were not using rituximab. However, they were using the induction with ATZ, and the antibody removal technique was the same with plasmapheresis and low-dose IVIG. Then came the Cedars-Sinai protocol, which uses high-dose IVIG both on POD0 and POD30, and with a single dose of rituximab in between on on day 15, and they are using induction of alemtuzumab or ATZ and with the standard protocol. Now, looking at the data, the outcomes of all these protocols, if you look at Johns Hopkins, 8 years follow-ups, 80.6% patient survival. They have not mentioned about the graft survival, and total number of patients who were transplanted was around more than 200. If you look at the Mayo Clinic, 2 years follow-up, 89% patient survival, 89% graft survival. Number of antibody-mediated rejection is around 41%, data on more than 100 patients. Then the Cedars-Sinai 2-year follow-up, 95% patient survival, 84% graft survival, 29% patient having AMR, and with a data on around 76 patients. A meta-analysis of all these data suggested that if you have in this meta-analysis, there were 725 patients, mean follow-up around 2 years. Numbers of rejection episodes were around 36%. AMR was seen in 28% of the patients. Patient survival at the table of at 2 years period was 95%, and the graft survival was 86% at 2 years. Then there are different publications that has come up, like this one in NEGM. This is HLA incompatible kidney transplant recipient and survival. They found that with the desensitization, the patient survival and the graft survival is better than remaining simply on dialysis, or even in patients who are on dialysis followed by a compatible transplant. And by 8 years, this survival interval was more than doubled. So even if the patient underwent a high-risk transplant, the chances of survival is better than being alone on dialysis. Then there came this study, HL-incompatible renal transplant, long-term outcomes similar to deceased donor transplantation. We can see that the 1 year, 5 year, and 10-year survival in HL-incompatible cohort was 95%, 88%, and 81%, whereas the graft survival was 95%, 85%, and 70%. Similar was the case from South Korean publication. They also showed that even the HLA incompatible and combined HLA and ABO incompatible had good 5-year graft survival. Another publication from from Germany, they also showed that they had good graft survival over the period of 1 year. And with all this knowledge, we also learned, and we started our desensitization program in our center in 2016, 1 year after we started the transplant program. Initially, we started with only Fro-cross-match positive recipients with DSA MFI less than 10,000. But and we did a little bit of publication also. In first of our 55 patients, where the 45 patients were on a regular follow-up for 1 year, we found that the graft survival and the patient survival is almost 100% at 1 year. Another publication we did in the next year, by 2020, we found that the first 200 incompatible transplants, whether it was ABO incompatible as well as the HLA incompatible, we found that the graft survival and the patient survival was at a period of 1 year was around 100%. Slowly, we took the road to the transplant in CDC cross-match positive recipients. So first of that case was done in May 2019, then subsequently in August 2019, November 2019, December 2019, again fifth case in December 2019, then 2020, because there was a COVID going on, so we stopped doing such kind of desensitizations. And then subsequently, over the next few years, we completed around 12 cases with CDC cross-match positive recipients. And after that, we changed the strategy because newer drugs were coming up. And subsequently, the next 3 cases we did with a different approach. For the first 12 cases, if you look at the statistics, the mean age of the recipients was around 40 years, 4 male, 8 of them were female. 1 of the patient was undergoing a second transplant. All the female were having a history of multiple pregnancies. All of these patients had a history of multiple blood transfusions, and the mean duration on dialysis before kidney transplant is around 2.6 years. 8 of them were purely ABO compatible and HLA incompatible, whereas 4 of them was both ABO incompatible as well as HLA incompatible with low antibody titers for the ABO antibody group of 1:16 or 4. Looking at their immunosuppressive status, they were highly sensitized, which was defined by a positive CDC cross match and a DSA levels of more than 10,000 MFI for a single antigen or more than 5,000 MFI for multiple donor antigens. If you look at the Luminex single antigen variation, in class 1, it varied from 16,507 to around 23,400, and class 2, it varied from around 5,500 to around 15,000 in different percents. And CTC cross match was either weak positive or strongly positive in all of these cases. Flow cross match was also positive in most of these patients, both T and B cell. This was our simple disassociation protocol, which is based on the John Hopkins protocol. We start with rituximab. We give plasmapheresis with low dose IVIG around 5 gram after every session. Start with the immunosuppressants. Do the transplant with anti-ATG induction. Give 1 dose of solemetrol. Follow up in the post-transplant period is simple. Looking at the graft function, we do a further plasmapheresis depending on whether there is any graft dysfunction or not, and looking at the DSA levels if that is required. So we gave rituximab 500 milligram in each of these patients. The mean number of plasma exchanges that were given pre-transplant was around 8.7. That means 9 plasma exchanges a mean of 9 plasma exchanges were received by every patient. We gave every patient 5 gram of IVIG after each session of PLEX. In 2 of the patients, when these were not working, even after 5 plasma exchanges, the titers were not going down. We additionally used bortezomib 2 milligram weekly subcutaneous for 4 doses. And this was given in 2 of the patients. In all the patients, the induction with thymoglobulin was given in a dose of around 3 milligram per gram body weight over 2 to 3 divided doses. Looking at the outcome, all these 12 patients, the mean discharge serum creatinine was around 0.89 milligram per deciliter. 2 of the patients had antibody-mediated rejection the first week, but they responded very well to plasmapheresis and IVIG in the post-transplant period. Including the above 2 centers, only 3 patients developed ABMR in the first year. So 2 of these in the first week and 1 in the first 3 months. So total conclusively, 3 patients developed ABMR. 1 patient in the post-op period required dialysis because of the ABMR in the post-transplant period. She became anuric and we have to start dialysis in her. One of the patients developed chronic ABMR, which is partially responsive to IV rituximab. The patient doesn't have any finances to further do DSAs and but he has almost completed 5 years post-transplant. One of the patient developed a coronary T cell mediated rejection, which responded to ATG in a dose of 3 milligram per gram body weight, and currently Sue is doing very well. One patient developed chronic TMA. Now the TAC doses have been reduced and the patient is having a stable graft function. One patient developed a recurrent IgA nephropathy, but there is no decline in the graft function. In only one patient, we found that there was a CMV viremia. He presented with diarrhea, and there was, when we further investigated, we found that there were some ulcers in the gut, and he was having CMV in the blood, and he was very well treated and responded to treatment. No other patient had got any major opportunistic infections. So this table shows the serum creatinine over the period of around from a day of discharge up to around 5 years for those who have completed 5 years. And this graph shows the serum creatinine serial changes in each of these patients. 1 or 2 of the patient had a rejection, those who were well treated. Looking at the mean serum creatinine value for the patients who have completed around different, like over the 5 years, this is the mean serum creatinine values that have been plotted. So with this, we were doing sufficiently, we are doing fairly good with the desensitization protocol, and we were very happy. But there were certain issues in this protocol. Patient were requiring too many plasma exchange sessions, and sometimes the duration of the plasma exchange were more than 20 days in some of the cases. There was a cost escalation because if you do a good number of plasma exchanges, there is a cost to it. And then some of the patient had issues with the coagulation parameters. Then there were two patients which were not in this cohort. They failed to desensitize to the current regimen. And there are two patients who had a post-transplant early ABMR. So we went for literature survey and tried to find out what best we can do, and we had to find something outside the box. So looking at the literature, we found that the options for the therapeutic intervention are at multiple levels. What we are targeting currently is the B cell. We are doing a B cell depletion with rituximab. Then there is a target of plasma cell. In two of my patients, I used the bortezomib, but that was not very effective. We are targeting the preformed antibodies, removing them by immunoabsorption. And then there are now eculizumab available in India, though I have not used in any of my patients till now in ABO and HLA incompatible transplants. We did not require it. But before around 6 months, it was not even available in the country. So these are the 4 stages where we can basically think about the therapeutic options. Looking at the rituximab, basically it works on pre-B cells, immature B cells, transition B cells, naive B cells, and the memory cells. Whereas you look at the daratumumab, which is basically anti-CD38. Where does it work? It works on the pro-B cells, it works on the pre-B cells, it works on the immature B cells, it works on the transition B cells. So most of the B cells phases, except for the naive B cell and the memory B cell, is not targeted by the CD38. And it very well works on the plasmablast and both on the short-lived as well as long-lived plasma cells. And we all know that the plasma cells are the one which basically generate the antibodies. So B cells transition into plasma cells, and the plasma cells are the ones which generate the antibodies. So even by targeting the B cells, we are not able to achieve an entire reduction in the antibody production. So even those plasma cells which were there, they need to be targeted. So targeting the plasma cells basically can lead to a rapid decline in the antibodies. So a combination of both CD20 molecule and the CD38 molecule can have a rapid reduction in the number of plasma cells as well as production of the antibodies and can lead to a rapid desensitization. And because it is acting on both short-lived as well as long-lived plasma cells, so the effect of the desensitization will remain for a longer time. So what are the experiences? We know that daratumumab is an anti-CD38 monoclonal antibody and culminated the plasma cells, reduce the preformed antibodies and lead to desensitization. What are the experiences in the world? This publication, which came in JASN in 2019, daratumumab in sensitized kidney transplantation, potentials and limitations of experimental and clinical use. They found that if we target the CD38 with daratumumab, it significantly reduces the anti-HLA antibodies and anti-HLA donor-specific antibodies in non-human primate model and in 2 of the transplant clinical cases before and after the transplant. So they used both before and after the transplantation. And this supports the investigation of daratumumab as a potential therapeutic strategy. However, further research was needed to establish it as a potential drug for the ABMR as well as the desensitization. Then another publication from China, what they did, they basically got a patient who was highly sensitized and was waiting for a cadaveric donations, cadaveric transplantation. So if you look at the desensitization, the M5 were of multiple antibodies were more than 10,000. So they went on to have 2 phases. One was the intensive phase and the maintenance phase. And in the intensive phase, they give daratumumab weekly for around 19 weeks and with weekly plasmapheresis and IVIG. And in the maintenance phase, they gave just one plasmapheresis and IVIG, and daratumumab was given monthly. Again, in the later part of the year, they again did plasmapheresis IVIG weekly and daratumumab weekly for the 4 doses. And with this, they found that there was a rapid decline in the number of DSAs in the phase 1, and that was maintained in the phase 2. That means the effect of daratumumab was prolonged with good decline in the MF5 values of the Luminex DSAs. And the patient underwent a successful kidney transplantation with cadaver donor after phase 2 with stable graft function even after 1 year. So these Chinese studies showed that even in the patients who are waiting on the transplant list with multiple high DSAs, they can be very well transplanted with a suitable donor if they undergo this kind of desensitization. Another publication, and this was from Germany, Daravoid 6 highly sensitized solid organ transplant display, AKCC and literature review, and it went to show that even single dose of daratumumab can be very useful in patients who are going for a solid organ transplant recipient. Then came the DADAR study. Again, this was a 2 phases study, step 1 and step 2, where in the step 1, they gave escalating doses of daratumumab for 4 weeks, and then they gave 8 weekly infusions of daratumumab in the dose of 16 milligram per gram body weight over the period of around 8 weeks. And they found that there was a substantial decline in the DSAs, and they found that these DSAs were complete return to the baseline level at around 12 months period. But they were satisfied that this daratumumab was basically working and there was a decline in the total number of DSAs. So with all this possible knowledge which was available, we tried to use that knowledge in one of our case, which was the case 13. Mr. K was a 43-year-old male with a history of multiple blood transfusion, 6 units over the last 1 year. He had a dialysis vintage of around 1 year. The prospective donor was a sister, which was ABO compatible, and this was the baseline CDC cross match, which was B positive. That means the cell lysis was around 30 to 50%, and the T cell and the B cell was both flow cross match was positive, and they had class 1 as well as class 2 PRA, which was positive. Looking at the baseline Luminex single antigen bead, in class 1, the maximum M5 was against A2O1, which was around 1400, but in class 2, there were multiple DSAs, both DRB1 and DQA1, and so many other, and the maximum M5 was around 15,000. So we started the desensitization protocol on this patient. First dose of rituximab was given around 500 milligram. Tacrolimus was started on the next day, and then weekly daratumumab was given in a dose of around 800 milligram for 4 doses, and a repeat single antigen bead was done. Single antigen bead assay was done, and we found that there was a substantial decline in the DSA levels. This was followed by plasmapheresis and IVIG. 5 gram of IVIG after every plasma exchange. A repeat single antigen bead assay was done, and once we had a target of around less than 3000 MFI of single antigen DSA, then we went ahead with the kidney transplant with ATG as an induction. In the post-transplant period, we kept on looking for any graft dysfunction. We kept on looking for any rise of the DSA, if any, and if there was any graft dysfunction, we were trying to do further plasmapheresis and IVIG. So looking at this patient, the DSA MFI came down to approximately 5,000 for class 2 and less than 1,000 to class 1 after the first rituximab followed by the daratumumab. So after the rituximab plus daratumumab, the MFI had come down from 15,000 to around 5,000 for class 2 and from around 2,000 to less than 1,000 for class 1. And the patient was followed by 3 plasma exchanges with IVIG, and this was the DSA before the transplant. With class 1 was totally eliminated, class 2 was showing a DSA-MFI of less than 3,000, and then we went ahead with the transplant, and this was the final cross match. The CTC was negative, flow was still positive because we know that the flow will remain positive even with the smaller DSAs. We transplanted. The discharge creatinine was around 1.01. 1 month post-transplant, the patient kidney was still good. And 6 months post-transplant, the patient is still having a GFR of around a serum creatinine of 0.9 milligram. There is no infection. There is no rejection till now. And we are planning to do further analysis of DSA at 12 months to find out what kind of DSAs are emerging or not. This was the DSA 1 month post-transplant after our regime. And we found that both class 1 and class 2 were nil after 1 month of the surgery. Second patient, we found that 60-year-old female, multiparous and history of multiple blood transfusion, baseline cross match with daughter as donor was CDC positive, TNB positive. Class 1 HLA against B58, the MFI was 2349, whereas the class 2, there were multiple MFI, multiple DSAs. The maximum was 11,438. So we again gave the similar kind of regimen, rituximab and daratumab, and found that after the initial therapy, uh, there was a reduction, there is substantial reduction in the DSIs, and finally, after the plasmapheresis, there is a 5 sessions of plasmapheresis. After that, the class 1 was nil, and class 2, the maximum 5 was only 1365, and he was transplanted some 3 months back and discharged on a creatinine of 0.9. Till now, he is having good top function. The last creatinine which was seen 3 months post-transplant was 0.8 milligram per deciliter. So he is doing very well currently. This is the third case. Again, 43-year-old male, CKD5 with a history of multiple blood transfusions. CDC was weak positive. DSA, T cell and B cell was positive. And if you look at the baseline DSAs, class 1, it was more than 10,000 against A2, O3, and class 2, there were multiple DSAs. The maximum MFI against DRB1 was around 16,000. Similarly, after the rituximab and daratumab, the DSA came down, the class 1 from around 10,000, it came down to around 7,000, and class 2, it came down from 16,000 to around 9,900. So after the 5 sessions of plasmapheresis, class 1 MFI was less than, was around 1,000, and class 2 MFI was around 2,400. So we went on to do the transplant with ATG induction. Patient was discharged with a serum creatinine of 0.79 milligram per deciliter, and 4 weeks post-transplant. Today, he still has got a creatinine of 0.87 milligram per deciliter. Today, he was seen in my OPD, and he came with a creatinine of 0.87 milligram per deciliter. Still, he is not having any graft dysfunction or any kind of rejection. So with these 3 back-to-back cases, it has given me kind of it has given me that I can further continue. And today we have taken the 4th patient for a similar regimen where the lady is CDC cross-match positive and DSAs are strongly positive. And we have given the first dose of rituximab 2 days. So today I'm started with the 4th patient. With all this, we also went on to have some publication. Like we did one of the publication for around 5 case series. First 5 cases where the CDC cross-match positive with the regimen that we discussed. And this patient had multiple DSAs varying from around 1,000 to around 23,000. And most of these patients are doing great by now that I've already shown you. We also published one case where the DSA was 30,000 in Indian Journal of Nephrology. And one of the publication went into transplant immunology. So this regime till now the current regime has been working very well. The previous regime was also good, but there are some lacunas. So we have moved to the new regime, and the patients are doing extremely good. So I just want to conclude my talk with that there is an unmet need for desensitization for candidate with the highest degree of sensitization, and we have to go on pursuing the newer therapeutic options which are available. And we are hopeful that like ABO incompatible transplant, which have become very common nowadays in most of the transplant centers, HLA incompatible transplants will also become very common, and we'll stop fearing these DSAs. At least we can be giving some year free of dialysis to our patients, and I think the patient will also be doing great, and they will be thankful for getting some life out of this, out of their chaotic life in dialysis. Thank you so much for your patient hearing.
Thank you, Dr. Vijay, and many congrats to you and for taking up such cases. And your presentation was brilliant, and it was seemingly good actually. Before to start the ball rolling, I have 2 questions. What is the cost of daratumab 800 milligram?
Cost of it, if you look at the MRP, it is around 1.5 lakhs. But
800 milligram.
800 milligram, yeah. For
Okay.
2 vials, it is around 72,000 rupees per vial. But if you give the patient out of the hospital, it costs around 1 lakh rupees.
Okay. What is your absolute contraindication not to take for this desensitization therapy? Do you have any absolute contraindications?
See, if the patient has got any ongoing infections or had got some history of very severe infections, which less likely to be
No,
treated, maybe had a
immunologically regarding DSAs.
DSS. See, till now we have tried DSA till the value of around 23,000. So I think the
Okay.
boundaries are getting decimated regularly. I don't see that if the patient is having a cross-match positive or T and B cell positive and is healthy enough to undergo this disease and therapy, I think probably every patient should be given a chance. Maybe uh, in some of the patient, you may not be as aggressive like giving weekly doses. You can give a monthly dose, and if as in the Chinese study, you see that there was a subsequent there was gradual decline in the MFI values. So patients who are ready to wait, you can give gradually escalating doses also of daratumumab, and you can wait for look at the DSAs at multiple intervals. If it is working fine, then definitely I think they should be transplanted in the future.
Any in post-transplant monitoring of DSAs?
Yeah, we are doing it at 0 month, sorry, 1 month, 3 months, and 6 months, and 1 year. So,
Any indication for plasmapheresis for that kind of DSA?
see, till
You
now,
need plasmapheresis based on DSS, increase in
uh,
DSA titers.
I have not even done a single plasmapheresis based on the DSA values unless there was a graft dysfunction. So in one of my patient who was developing a chronic ABMR, we did a biopsy. We found that a chronic ABMR is there, and the DSAs were persistently around 5,000, 6,000. So we in fact gave him 1 dose of rituximab and gave a second dose after 3 months. The DSAs were in the range of 5,000. Creatinine was a little bit creeping. I asked the patient to undergo for plasmapheresis and IVIG, but somehow because of the financial reason, he did not do it. But he has already completed 5 years of post-transplant period with a creatinine of around 4 milligram per deciliter. So he's still doing good.
Thank you.
He's not requiring dialysis.
Thank you, Vijay. A lot of questions are there in the chat box also. I leave it to panelists. Dr. Vishwanath, your comments, please.
Excellent work, Vijay. You have got very good results. I mean, in general, we will see that CDC cross-match positive precludes transplant, which you have crossed the boundary. My question to you is: any patient had BKV with such an intense program
Till
of?
now, none of the patient had BKV. One of the patient had CMV that I told you that he
Yeah, yeah.
CMV-related diarrhea. I normally give prophylaxis of CMV for 6 months and Cetron for cotrimoxazole for 6 months in all these patients who are having who have undergone desensitization. So till now, we have not had any major infections. None of the patient had developed a BK virus nephropathy till now. Maybe the subset is the number of patients that have done this kind of desensitization is very limited. But in other patients where I have done a desensitization, which is almost more than 250 patients where I've desensitized with less MFIs, some of these patients have done definitely have BK virus nephropathy. So I accept that some of these patients may develop BK virus nephropathy in the future, but that is acceptable. That is acceptable.
Thank you.
What is your recommendation if somebody is on the wait list for cadaver with high titers?
I think what previously we were trying to do is we were giving the Cedars-Sinai protocol. Now with this protocol, which is getting published, in fact, there is one study that is going on. They are enrolling the patient is ATTAIN study, where they're using uh, daratumumab and a combination of with Betalacept. So that study is going on in United States. They're using for the desensitization of patients who are on the wait list. Daratumumab with a combination of Betalacept. The other study was the similar for the patient who are on the waiting list. They have found that there was a substantial reduction in the DSS, but that was only lasting up to a period of a year.
Yeah.
Whereas if you look at the Chinese study, what they have done, they have went on doing the giving the daratumumab, plasmapheresis, and IVIG for a period of more than a year. So I think even in the patients who are waiting for cadaveric transplant, they can be offered this kind of desensitization.
Excellent work. We had similarly two cadaver transplants whom I did. I mean, they were waiting for the transplant. We did virtual cross match and we had given rituximab and kept giving IVIG. Luckily, their virtual came negative and they are doing well. I mean, one of them was the third transplant, in fact.
That's
So,
great.
I mean,
That's great.
can
So
be
we
used in
have to
cadaver as well.
recommend the
Thank
same.
you. Thank you. Dr.
Excellent.
Jayant, Yeah.
Excellent
Thank you.
presentation, Dr. Bijay Sinha, and he is a very good dear friend, being an alumnus of Apollo. So I remember my first, weekly positive CTC positive with very high MFI has already completed around 10 years
Oh,
post
that's great.
transplant.
That's great.
Yeah,
Great,
so
great,
it is
great.
just a myth, and we have been doing, discussing it for last many years. And Dr. Sinha has been presenting his work in my conference for last maybe 6, 7, 8 years. And I am the one who actually, against all odds, we thought of, going ahead with, CTC cross-match positive transplantations and, all those MFIs. I was just inquiring, Dr. Sinha, are you also using these HLA columns? Are you using,
In two of my patients, I used the HLA column.
yeah,
I told you that two of the patients failed desensitization with the previous regime. At the time, I was not using daratumumab. I was not aware of it. So in those two patients, I even tried to use the column. But when the column failed, I'm not sure that really the column works because a lot of cost happened.
yeah,
The DSAs were the same even after doing the column desensitization. So I have stopped using the column now. But we tried in two patients and we were not very lucky with
no.
it.
And another molecule, there are people, I remember of Dr. Varun Verma, who also has good experience with this highly
Tocilizumab.
sensitized patient, is use of tocilizumab. So any experience of tocilizumab in this category of
One of my
patient?
patients who were having he was not CDC cross-match positive. He
He
was
was not positive. High DSA, but not CDC was not
high
positive.
DSA, but in that patient, I used tocilizumab. There was some kind of reduction of DSA, but not to that extent that
Concern is the rebound of DSA. As soon
amount of
as you
DSA.
taper up the tocilizumab,
Daratumumab is
it's more of a receptor blocker. So again, there
yeah,
will be surge of IL-6 and all those things.
yeah.
Good,
So
very good.
daratumumab is performing
In
best,
that way, daratumab is doing better. Yeah,
doing better.
very
Yeah,
good.
thank you, Doctor.
Possibly,
Excellent.
but still, I think it's doing better than the
Yeah.
other. So I have included
Thank you, Doctor.
that I inducted the fourth patient today on daratumumab.
Very good. All the best, and keep doing
Thank
your
you so much.
good work.
Thank you so
Thank you,
much.
Dr.
Okay,
Shota.
thank you so much.
There is one question from Dr. Vail to Sinha. That is actually, he has one patient in HLA-DR-B1 with the MFI around 16,000. The rest of all negative, and the flow is negative, and his CDC plasma is also negative. He proceeded with the transplant with a few sessions of plasmapheresis and IVIG, but still patient developed ABMR, that is hyperactivity probably, and they could not able to solve the graft. What could went wrong in that kind of patient?
So DR-B1, what was the titer when
Yeah.
before the transplant? From 16,000, it came down to around less than 5,000? Or was
I
it
think he
still?
hasn't seen that. Actually, he hasn't
We didn't
noticed
see it, Rajveer. That's the reason. We didn't see because
that.
flow
Yeah.
CDs were negative. We didn't do it actually. Then now,
Yeah.
Actually,
I think
sir, we can keep a class separately on this. See, there are a lot of issues with DSA. What Dr. Sinha is doing is actually true HLA DSAs, where the cross-match is positive. But if the cross-match is not positive, we are not sure whether they are complement binding or not binding. Even otherwise also, even in DSA negative patients also, we are getting a lot of ABMRs. Maybe these are non-HLA DSAs. We really don't know. The one what Dr. Sinha is saying, we are 100% sure, yes, these are complement fixing antibodies. But if CDC is negative, despite the MFI being very high, also we are not sure whether they are complement fixing or not fixing. We had got very good response with DSA more than 20,000, okay, without rejections, without anything. But even with low DSAs also, MFI of less than 3,000 also, we are getting very resistant ABMRs. So probably we really don't know whether we're dealing with non-HLAs, non-HLA DSAs. So in the coming years, maybe there is one particular study in PGI Chandigarh, where they are looking at anti-endothelial antibodies. So see, the antibodies can be anti-endothelial, it can be anti-muscular antibodies, it can be any damn kind of antibodies, be it HLA, be it non-HLA. So what we are talking right now is this anti-HLA antibodies, which are CDC positive. That means they are truly complement fixing antibodies. So the
But
other
we
way
don't
around is
understand
not,
this.
we are not sure whether even
Yeah.
if the DSA is negative, still you can get ABMRs. I mean, we are getting
And
Some-
you
it.
don't have a
some of the
standardization for
centers are-
non-HLA antibodies also, titer also.
Yeah.
Don't have a
Sorry to interrupt,
standardization.
sir. Some of the centers in West are now doing the C1q binding.
That's what. That's ideally we should be doing either C1q antibodies and or the C3d antibodies. But somehow in our centers, I mean in Delhi and
Northern
NCR,
India, yeah.
we are not getting those C3d positive or C1q fixing antibodies. But the one what you are doing, I mean, if the CTC is positive, that means it is complement fixing. I mean,
Complement, right.
no denying.
No denial, yeah.
But the other way around is we are not sure whether they are really complement fixing or not, and how much desensitization should be done to those antibodies. We really don't know. Anyways.
Dr. Sinha, we are running short. And
Yeah.
just one last question. Last question.
Very challenging, very interesting. Yeah.
Yeah, very interesting. And suppose these kind of your daratumumab and rituximab, this kind of protocol, you use for all kind of DSAs, or you have any cutoff to do this kind of protocols? What is your
See, currently I'm
DSA
only using
levels?
currently I'm using only because these are costly medicines and they also have the potential of doing a lot of infections. So I'm only using daratumumab when there is a CTC positive or a flow positive with a strong DSA of more than around 10,000. So I have not used in patients where the MFI was less than 10,000. Of course,
What
in
is the protocol for less than 10,000? What is the protocol?
the protocol that I described in the beginning, plasmapheresis, IVIG, the John Hopkins protocol that most of the centers are using. Plasmapheresis, IVIG, first rituximab 500 milligram, and then ATG induction and transplant. That we were successful doing it for quite many years. We have done around 200 transplant with DSA-MFI less than 10,000.
In your experience, when you don't do the desensitization protocol, what is your level? What is your DSA cutoff for not doing a desensitization?
See,
There
till
is
now,
no absolute contraindication.
till now, I told you that apart from infections, if the patient has agreed.
No. What I'm asking is.
Is there any absolute contraindication? I mean.
No. What I'm asking is, what is the because low MFI levels, that is, what is the level below after which you do the desensitization? Below which level you don't do in desensitization?
3,000. Below 3,000, I am not doing anything. Between 3,000 to 5,000, I'm just giving one dose of rituximab, maybe 100 milligram, and one session of plasmapheresis. That's all.
So what I do, and I have been, I'm an advisor to a lot of newer centers also. A lot of my juniors are doing transplants. So what I am trying to do and what we follow, and we are getting good response, is that you have to first classify what is the kind of patient you are dealing with. Let us say there's a naive patient, one young boy has come, okay, there's no blood transfusion for the, let us say, mother to son or father to son. There's no risk, so to say, of any HLA sensitization. There, even if the DSAs is, let us say, 5,000, you are not going to go to very aggressive desensitization in such a case. You can go with only ATG induction maybe. But let us say there's a patient with a multiparas lady, or let us say there's history of blood transfusion, repeated units of blood transfusion. Even with the DSAs, let us say around 3,000 or maybe 3,500, you have to do some plasma exchange. Okay, and many a center, what is happening in even our center, I'm there at Apollo Delhi, even in our centers, we are not able to repeat the DSAs because of the cost and, a lot of issues. So many times what we are doing is we are looking at the, the pre-transplant, the risk immunoprofile of the patient. And then we are taking a call on our experience and, the way we are dealing in our centers. Most of the time, more than 95% of the time, they are just selling smoothly.
That's
5% of the time, even if you are, even if the DSA is negative, you may land them in a trouble. Even if the DSA is negative, you really don't know, because we really don't know whether they are complement fixing or not. Because the CTC is positive, MFI is barely 3,000, 3,500. In such kind of situation, you really don't know whether you are. So what we are doing is, let us say there's a patient of second transplant, third transplant, history of multiple transfusion. Just now, yesterday we discharged a patient. Second transplant, the patient has got a GIST, one GI.
Dr. Jain?
I think we have lost connection with Dr. Jain.
We lost him.
Thank you,
Yeah.
Dr. Sinha, that actually we have running short of time.
Yeah.
And thank you for your wonderful presentation. And
Thank you, sir.
there are
Thank
a
you, sir.
lot of light in this. Actually, this is a very new concept for us. And thank you. And
So my last submission would be that we have to be brave enough and desensitize ourselves and accept the patients who are having flow cross match or CTC cross match positive. Probably that's the way to go forward. Probably In the world, when Japan did hundreds of ABN computer transplant, people started doing it. So when I met Dr. Tanabe, you were there. So I was just discussing with him. I have met him at multiple times also. So he had the courage and conviction to go ahead with ABN computer transplant. So probably we should also have the conviction to go ahead and do the HLN computer transplants. Maybe even if we give 5 years, 6 years, 10 years of good graft function to the patient, that is better than the patient who are lying in the bed on dialysis.
Thank you, Dr. Sinha. Thank you very much.
Thank you so much. Thank you so much.
Dr. Nagendran, you can share your presentation. Start
Yes,
your presentation, please.
So, can you able to see the screen, sir?
Yeah.
Yes, sir. I'm Dr. Nagendran. I'm from Erode, Tamil Nadu, sir. Thanks for Peculiar Case Scenario Group, Rajarajan sir and Dr. Velaran sir for giving me this opportunity to present. My case is CKD with the coral leaf aortoiliac occlusions disease. How we have done a transplant for it. One. The patient is a recipient, 56-year-old. We have done a swab. We have planned for a swab transplant because of blood group incompatible, incompatibility. My two recipient. One of the recipient is Chandrasekhar. He is 56-year-old. He has CKD since 2013. And we initiated a dialysis in 2020 and done a fistula, BC fistula on left side on 2020. And he is an heavy smoker. Dialysis vintage is on dialysis for last 5 years. And he had an left BC fistula failed. And last 1 year before transplant, he is in left palm catheter. All the access has been lost. And his thrice weekly dialysis used to come, and he has a frequent complication during dialysis. Like he used to complain with bilateral knee pain, and he had no history of blood transfusions and family history of kidney disease, and his native urine output is less than 50 ml. And we planned for a transplant, and we had done a CAG since he is an heavy smoker and more than 45 years. CAG double vessel disease, and we planned for a conservative management. And issues before doing transplant, he had a polyp in a large bowel that was operated to rule out the malignancy, and he had a CAD, double vessel disease was there. And this is I was doing a presentation before our team, since it is a swab, and we planned. I missed a Doppler for this man. And we have done it next day, 1 week before a surgery. And it was showing peripheral vascular disease with occlusive disease with extensive calcification in the aortic and iliac segment. And we have done a CECT. This suggestive of diffuse circumferential calcification plaque with more than 40% luminal narrowing below the infrarenal part in common iliac, external, internal, all the vessels have diffuse calcification was there. And we have taken a retrospective history. Later, he suggested of pain bilaterally that is more towards right than the left, and bilateral claudication pain was there, and erectile dysfunction was there. And patient was very hesitant to tell, and I also lost my questions in probing the leg pain. And we are in a very deep problematic situation where we planned for a swab 1 week before we identified a difficult scenario. Another this recipient as well as another recipient, both of them is not doing well in dialysis. So I required help from my colleague. He is my UG batchmate, Dr. Murali. He is a vascular surgeon from Tanjore. He will clearly explain about further workup in vascular access. Dr. Murali can join.
Yeah. Thank you, Nagendran, and thank you, Rajarajan sir, for the early introduction. Next slide, Nagu. If you could just change slide. So once Nagendran sent the patient to me, and then I evaluated the patient. He had a palpable feeble femoral pulse on the left side, and no pulses below. On the right side, there was no pulses palpable. So we decided to go ahead and get the angiogram sorted for this patient. So his ABPI, the blood flow in the limbs were like 0.7 in the left side and 0.5 in the right side. We expected to be 1 on each side, but it was less, 0.5, almost 50% on the right side and around 70% on the left side. This could explain why he was having a claudication pain initially. Next slide, please. So the CT angiogram showed this. If you could see this, the blue arrow, the red arrow shows all the calcification, but luckily the calcification stops short at the aorta and iliac level, and there are no calcification in the external iliac artery. And when you look at the coral reef can be a hard coral reef or a soft coral. These coral reef calcification are considered as hard coral calcification. So whenever we try to do any intervention, take a bite or put a needle, it will be very difficult to pass the needle through the blood vessel. So it will be very difficult. So we had to revascularize the blood vessel before doing any sort of transplantation. Next slide, please. So we can see on this side, the left top extreme, the aorta is heavily calcified. The aortic bifurcation on the is calcified. And next slide, please. So you can see the femoral arteries on both sides are also heavily diseased. So revascularizing through another aspect is not possible. So we had all these options on the table. Either do an aortobifemoral bypass or aortic endarterectomy along with the renal transplantation. The third option was doing a simple, relatively lesser invasive aortoiliac angioplasty with stenting and renal transplantation at external iliac artery. Or sometimes we can do a synthetic graft for bypass to the kidney, right from suprarenal aorta. But since the patient had a double vessel disease and he had a heavy smoker, he was not a good candidate to undergo a major abdominal surgery. And aortobifemoral bypass, aortic endarterectomy would require very morbid, like lot of dissection, and he will have to undergo prolonged duration of anesthesia. So we decided, after discussing with the patient, we decided to go ahead with aortoiliac angioplasty. Next slide, please. And the patient were also accepting. The only problem is it does not have a durable procedure, but it is good enough in many of the cases. And we decided that we will transplant the renal artery to native side. So we tried revascularizing both the iliac artery, but we were able to revascularize the left iliac artery. And you can see the wire coming from the left femoral artery through the iliac. We did angioplasty of the left aorta and the left common iliac artery. And next slide, please. We kept the stent graft as a backup, just in case if the patient has a rupture of the vessel. And aortic angioplasty was done with the 12 mm balloon. The native aorta was around 16 mm. We did angioplasty till 12 mm. And left iliac artery has angioplasty with a 6 mm, and sequentially further inflated to 8 mm. We placed a stent. We also wanted to revascularize the right side, but the right side we couldn't. It was a very tight occlusion, could not be revascularized. So we went ahead and revascularized the left side, and then we did the primary transplantation with the kidney on the left side. Next slide. So with the palpable femoral pulse and ABI, which is improved to 0.9. Previously it was 0.7. Right side also ABI is improved because aorta has been aplasty. There was a small puncture site hematoma, and postoperatively there was no other issues. Next slide. So we did a ATG induction and left donor nephrectomy.
And we plan to since patient we have donor we have planned for left, and graft we thought we will place it on left side since the flow was good in left. We thought of placing in left iliac vessels with the high risk anesthesia. And before planning for transplant, we plan to open the recipient first, do anesthesia, whether the surgery is possible, then only we plan to open the donor. So we first open the recipient and see the vessel whether it is good enough to place the graft, and then only we plan to open the give anesthesia to the donor. And the patient underwent a transplant on 13/7/2025. Immediate graft urine output was good. He had a small issue of urinary retention, and later fifth day after removing the catheter, the trial void we tried for 2 times, but we failed. And UDS we have done, and bladder outlet obstruction was there, and we operated. better now. Post-transplant 10 month, he is doing well, and his lower limb symptoms also improved. He started doing his routine works, and he's doing better. And another recipient is also doing better. The final Thank you. The final thing what I've learned is to make the bedside examinations and clinical hearing the patient history is more important to avoid this scenarios. If I have done the my bedside clinical examination and history taking, I would not done this case because I would have deferred. Simply I deferred since I have done all the workup. Finally, before 1 week before the transplant, we end up in this complication. Then I got help from Murli. Somehow we came out of this scenario. Thank you.
Thank you, Dr. Mahendran, and thank you. Just one of the important thing you have stressed upon that clinical examination is very important in such kind of patients. And I understand your mental trauma you would have underwent when you do a transplant transfer, suddenly seeing the patient not fit for doing anastomosis and all. And luckily you got through. And thank you, Murli, for the wonderful work you've done and make the patient get transplanted. And Dr. Vishnu sir, your comments, please.
Good work by Dr. Nagendran. Last minute, at least they were able to salvage the patient. Dr. Murli, good work. Any thoughts about placing a graft instead of doing other things? I mean, we had one similar patient, and then one of my colleagues, Dr. Ravi Jangamani, was there. It was published also. With the help of CTVS surgeons, they had placed a graft and then AV graft, and kidney was anastomosed to the graft. I think Vail may be able to comment on this.
Yes, sir. We did once. We did once like that.
Yes.
This is feasible, sir. But and the expert is Dr. Murli, and he can do a lot of. You would have faced a lot of such situations. So that's why we went ahead with a stenting.
Yes.
It's a heroic work, sir.
Absolutely.
Thing is, it's a swab transplant. I don't know how Nagendran went through such turmoil, right?
Dr. Kauta?
One thing in the coral reef calcification, apart from the other atherosclerotic diseases, like it is not very easy to operate on this. It is not very easy to take sutures. So even like when you have to take sutures, the similar so they have a calcium score in case of a cardiac. Whenever you look at the cardiologist, they will say some calcium score to look at the coronaries. So these calcium, if this coral reef calcification is there, they will not do any coronary stenting because they have high risk for rupture, and the suturing also is very difficult. But only thing is we have to find out a normal segment of aorta or normal segment of artery to anastomose it. Sadly for him, below the renal level, he does not have any normal segment of artery apart from the external iliac. So we have to bring blood till the external iliac to do any anastomosis. Otherwise, he will need a suprarenal clamp, which will have high morbidity to the patient. He will have already his cardiac status is very compromised. So that's the reason why, in fact, one of the options which we kept in our hand is to have a graft be placed. But we decided against it because he has a bad cardiac background. That's the reason why we did not do it, sir.
One last question, Murli, actually, it made sound simple. Actually, if you have a patient with this kind of calcification, but doesn't have any peripheral artery disease like your ABP or XM normal and doesn't have any claudication and all, and pulses are felt, and what would be your approach like this? Similar kind of patients with no clinical evidence of peripheral artery disease.
So once we take control of the external iliac artery, if we can put an arterial line, and if the arterial line pressures are almost equal or less than 10 millimeter difference between upper limb arterial line pressures, then we can straight away go ahead and do the anastomosis. If the arterial pressure difference is going to be more than 20 millimeters of mercury difference, that means there is a significant stenosis in the intervening segment. So the intra-arterial pressure, invasive pressure monitoring will help us tell whether this patient is having a bad inflow vessel for renal transplantation or not. So we can do it through a coronary, like a angiogram, very invasive angiogram. We can keep the catheters there. We can measure the pressures. If the pressures are fine, we don't need to do it. If the pressures are less than 20 in the comparison to upper limb, then it is better to do the angioplasty of the narrowed segment.
Thank you. Your point is well taken, actually.
Just one
Thank you,
question.
Dr.
One of our patient, our transplant surgeon did anastomosis, similar kind of patient, where there was a lot of atherosclerosis in the aorta. So what he did, he used a splenic artery for this thing.
That
And
was
we have 2 or 3 patients where the splenic artery was used for anastomosis, and the grafts are working very well.
It's
Where did you place the graft actually? Intraperitoneal?
this orthotopic transplant, Raj. Just
Okay,
they'll
okay,
place near the native kidney.
Okay.
That's what
Good.
even we had a similar patient, but that patient didn't come up for transplant.
Okay. Thank you. So we have exceeded our time, and thank you for the wonderful, exciting session. And thank you, the speakers, for making us alive. And we have a lot of take-home message from your both the presentations, and especially Dr. Sinha, you have done a great work, and good to know that your work here.
Thank you.
And thank you, the panelists, for spending the time and discussing. And we have indebted to you for making this discussion live. And thank you to the participants who have been the pillar of support for us, and the MQ team who has given the AV support. And it would take a lot of things actually. We have taken home a lot of messages from your presentations, both of your presentations. And we try to work it out on our next waiting patients. A lot of patients are there waiting with a lot of MFI, and we have our fingers crossed up to whether to do a transplant or not. And your presentation has given a lot of confidence to venture into such kind of acts. And thank you, Arundel, for attending this meeting. And we're looking forward for our next meeting, which will be on June 1st, Saturday. And we invite the institutions to come up with the presentation so that we can discuss, share, and grow with each other. Thank you, one and all, for your
Thank you, Dr. Rajan. Thank you very much.
Good night, Vijay. We learned a lot from you, Nagendra and Vijay, and
Thank you, sir.
and Vijay has given a lot of courage for us.
Yes.
And
Thank you,
thanks.
sir.
Good night.
Thank you, sir. Good night, sir.
Thank you, sir. Good night.